All right. Good afternoon, everybody. We're very excited to have you here. We're just going to give everyone a moment to log in. Thank you, everybody, for taking some time out to join us today. We're just going to give the group one more minute or so before we start. All right, fantastic. Welcome again. Let's get started. My name is Rebecca Wallach. I'm the director of the Evelyn Frank Legal Resources Program at NILAG. We're happy that you're here today to join us for the next hour and a half to learn about Medicaid home care, how to navigate Medicaid managed care to get the services your client needs. I'm joined today by two amazing colleagues, Ana Maria Cardenas, who's a staff attorney on our team, and Peter Travitsky, a supervising attorney on our team. They will be taking us through this training. But before we get started, I will just share a little bit of housekeeping, if you could move to the next slide. So today's presentation is a webinar. Everyone is on mute. If you can post your questions in the Q&A, we will do our best to answer those during the training. We will send out a copy of the slides. You will receive them through Zoom. People who registered will receive them and attended, and even those who did not attend. And we will also put a recording of the presentation up on NILAG, New York Legal Assistance Group's YouTube page, and include that in the email that we send out through Zoom. And please, you're very welcome to share information and materials with others. So with that, I will turn it over to Peter.
Thank you, Rebecca. Sorry, I'm just switching over to another slide deck. Just 1 second. All right. So before we launch into the formal presentation, that's the wrong one. Sorry, I clicked the wrong slide deck. Before we launch into the formal presentation, I am going to put on my ICAN hat to talk to you a little bit about the Independent Consumer Advocacy Network and also to set the table for the rest of our talk today. So first, what is ICAN? If you attended our last, the part 1 of this series, I did talk a bit about this at length, but just as a refresher, ICAN is a statewide ombuds program that helps consumers navigate challenges regarding access to home and community-based services and behavioral health through Medicaid managed care plans. And we help people navigate problems and also challenge actions taken by managed care plans. We advise, we answer questions from a basic understanding of what a managed care plan even is, the plan options you have, procedures to follow to enroll in a plan if you're not already in one, all the way to more complex issues requiring complaints and appeals to access necessary care. And we'll talk to anyone about long-term care and behavioral health through managed care plans. But if you are asking us to do something on behalf of a consumer, we will need their permission to the consumer's permission to really do more than advise. Uh, we help with all Medicaid managed care plans that provide these services. And I'm sorry, this slide is a little outdated because it lists the FIDA IDD product, which ended as of January 1st, but it accounted for a pretty small segment of the home care population. So setting that aside, uh, the main reason I wanted to show you this today is that there are uh, several lines of business here. The managed care web in New York State is uh, a pretty pretty vast. And on top of that, there are many healthcare companies that are in the mix, and they vary by region across the state. They may offer more than one managed care product. Just so, for instance, like Fidelis Care offers an MLTC plan, a Medicaid Advantage Plus plan, a mainstream managed care plan, and a health and recovery plan or a HARP plan. But I'm not picking on them. It really is that way for most health insurance companies. Uh, and it's very important to not be overwhelmed by that. I think this time last year I gave a training, and like 5 minutes before I signed on, I tallied up just based on health insurance company and plan option, like what's the total number? And in New York City, it was something like 50, 52. Um, so like that's huge, right? Like somebody entering this market is entering, and you know that's accounting for each health insurance company's different product offerings. And that's a lot. That's overwhelming if you're a consumer entering this market. So it's great that ICAN exists, and it's great that you're here to learn more about how you can help yourself, your clients, each other, um, because the dirty little secret is that regardless of which plan you're in or which company is providing that plan, the rules for service authorization are the same. The same. Okay, we're going to repeat that a lot today. The same. Oh, my nurse care manager said it's the same. They're the same. The rules are the same for authorization of services. So who is ICAN? We are statewide, as I said. We're funded through the Department of Health. The lead agency in ICAN is Community Service Society right here in New York City, which is why you'll see that these slides are co-branded. And then there's probably a lot of organizations included in the network that you're already familiar with or that you may have heard of, like the Medicare Rights Center. Uh, I know they're a big one. Center for Independence of the Disabled, New York, they're a big one. I mean, all of them are big. All of these organizations are great. Um, we operate a hotline in New York City, or I should say, the hotline is staffed by the advocates who are based in New York City. But if you are seeking assistance in Northern or Western New York, or I don't know if that includes the whole state, but anywhere outside of New York City, we can get you to an advocate there who can counsel you. It just so happens that by volume, most of the home care recipients in the state do live in downstate New York. Um, our counselors care about language access. We have counselors that speak different languages, and if we don't speak them, we will get you an interpreter. We give trainings like this. We monitor cases for potential trends and report them to the Department of Health. Sometimes the state listens to us, sometimes they don't, but it's still great to have their ear. Our services are completely free and confidential, and we will meet you where you're at. Okay, so what is MLTC? MLTC is a plan type, but it's also a universe. So when we talk about all of the plans that I just listed on that previous slide, many folks, if you attended another training, they may just refer to all of those plans collectively as MLTC. But conceptually, what we're really talking about is just plans that cover long-term care, home care, adult daycare, nursing, short-term nursing home, Although there are a couple of plans that include Medicare and Medicaid that would cover nursing home long term, but we're not talking about that today. Medical supplies, transportation. Again, that buzzword, same. All of them must follow the same rules as each other and as the Medicaid program. Some of the plans may cover different services. For instance, there are Medicare plans mixed in that may offer an over-the-counter card benefit or a gym membership. But uh, those and that there you may see some variation, but for the services that we're talking about today, it all must be the same. You get a care manager when you're in a plan. A care manager is by contract supposed to visit at least twice a year, and they're also supposed to do a monthly check-in call. Now, I'm sure there are people that are rolling their eyes. I know that care managers have bad raps, reputations. They really, I think they have a lot of cases, and they also don't have a ton of power at plans. At least that's what I've experienced. Um, you can call them. Great to call. They are your voice in the plan. But one of the other themes that we're going to be talking about today is when it comes to the big decisions, the big changes you want to make or the complaints that you want to make, it's best to submit those in writing to the plan so you can track it for yourself. Because you just have no way of knowing if the care manager's voice is going to get lost in the mix. Okay, now for a prerequisite to getting help from ICAN is the person has to have Medicaid. If they don't have Medicaid, then you really can't be an ICAN client, and because you're not eligible to enroll in a plan. So that's step one. Um, and I think Rebecca may be putting in the facilitated enroller list, but if you're here for somebody who doesn't have Medicaid yet, um, a facilitated enroller is a good place to start to screen you for Medicaid enrollment. The next question is, do you have Medicare? Ha Having Medicare really defines your plan options. Folks without Medicare are most likely going to be in a mainstream managed care plan. And these plans cover, I mean, these are your only health insurance if you're in a mainstream managed care plan. So they cover doctors, hospitals, long-term care. They do not cover the pharmacy benefit. A couple of years ago, that was carved out. So folks in these plans do get drug coverage, but it's from the state directly through a program called New York RX. But folks who have Medicare can choose from one of three plans. I know the slide says four, but again, FIDA IDD ended at the end of 2025. MLTC PACE, Program of All-Inclusive Care for the Elderly, I think is the last word, and Medicaid Advantage Plus or MAP. So for PACE and MAP, these two options combine everything, Medicare and Medicaid and home care. And I'll talk a little bit about how they're different in a minute, but I'll say most folks who like these plans like the convenience of having everything under one roof, one card for your Medicare, for your drug coverage, for your long-term care. Others don't. They tend to go to MLTC, which allows them to preserve whatever their Medicare coverage is. The majority of people who need home care are in MLTC. So this is a separate plan from your Medicare. You would have a Medicare card plus a card just for the MLTC, and you have the ability to continue seeing your doctors. Let's skip over that. So the combined plans, as I mentioned, you are confined to the plans network, but they may be more convenient for you. And I should also say that if you're somebody who was in a mainstream plan who ages or disables onto Medicare, you're already used to having a confined network because you've been in a mainstream plan, and hopefully there is network overlap between the mainstream plan and the Medicare plan that you end up in. So those plans may be good for folks who are becoming eligible for Medicare who are already on Medicaid, but others have complained about network restrictions. Um, if suffice it to say, when you enter one of these plans, you really want to make sure that all of your doctors are in network. You also want to make sure that your drugs are going to be covered. So PACE, uh, we don't have a ton of these in the state, but that is changing slowly. You have to be 55 or older. And here, in a PACE plan, um, you go, everything is under one roof, literally, not just the card, but the place. You get all your services at a PACE center. I once upon a time I was a home attendant for a man whose family paid me privately, and he was also enrolled in a PACE plan. His family loved it because they came, got him, brought him to the center. He was very social, and that got him out of his wife's hair because she didn't really handle his dementia very well. Um, but like I said, enrollment is lower. In 12 years at NILAG, I think I've seen three PACE members. Medicaid Advantage Plus, like PACE, um, everything is under one roof, but not literally. Now it's just the card. And there is no the age restriction is not the same. You have to be 18, not 55. Uh, and again, because it's a Medicare product, you might get some extra benefits like an over-the-counter card or a gym membership. Okay, I think I'm gonna breeze through the next couple of slides because I am nearing the end of this section. I want to get to the meat of this training. But reminder that when we talk about requesting services from a plan, to keep in mind the way the plan is structured. The plan is not providing services. They have contractors that they pay to provide the services. Once they provide those services, they coordinate your care. But they're driving. Uh, I don't have a good analogy for this, but I wanted to say they were driving the bus, but they're not the wheels. But that's not a very good analogy. Anyway, um, okay, so like I said before, when trying to communicate with your plan for the big decisions, do it in writing. Keep proof of what you requested so you can track it. These things, as you'll see in the next slide deck, are subject to timing restrictions, and you may need to enforce those timing restrictions. Uh, you also have the right to written notice whenever the plan says no to you or takes something away from you. I'm sorry, Ana Maria is going to give us some examples of notices, but they all have to follow a model notice. And this is the basic format of it. So they're pretty easy to identify when you're checking the mail. You, of course, have the right to appeal. We're going to talk about appeals a bit today. And then to get help from ICAN, this is our information. Uh, the Any notice that a consumer gets from a plan should contain ICANN's information also. So if you're scrambling to write it down, you don't really need to do that because it's pretty easy to get. Okay, now I'm going to switch over and I'm going to ask, as soon as I get the slides up, I'm going to ask Ana Maria to talk a little bit about NILAG. Oh my gosh. Okay. Share and slideshow. Okay, go ahead. Sorry.
Okay, next slide, please. Okay, so again, my name is Ana Maria Cardenas, and NILAG is a civil legal services organization. In addition to assisting older adults and people with disabilities, and ensuring access to healthcare and home care. Our organization is also protecting and advocating for LGBTQ plus rights, help survivors of intimate partner violence, seeking safety for themselves and their children, individuals and families facing evictions, veterans facing denial of benefits, families in need of subsistence benefits, such as food stamps, immigrants fleeing torture and persecution who need protection in the U.S., children with disabilities denied an appropriate education, and workers whose wages were stolen. We do not practice tort law nor criminal law. Next slide. Okay, the Evelyn Frank Legal Resources Program, we offer several services, counseling on Medicaid and Medicare and home care eligibility and services. We also train legal and social services and healthcare professionals about changes in the healthcare programs and how to best serve the health and long-term care of older adults and people with disabilities. We represent people in denials and reductions of Medicaid, Medicare Savings Program, and Medicaid home care, and we assist clients with accessing Medicaid home care through managed long-term care plans. Next slide. This is our website. It's a www.newyorkhealthaccess.org. It was recently redesigned to be easier to use. We often use this tool ourselves, and it's relied upon by advocates as well as consumers. We often cite this source when sharing information with clients. It is updated frequently to reflect the most current policy information as well as changes and explanations of the current law. So it's a great resource for everyone. Next slide.
Okay, so we heard that people liked the Wizard of Oz theme of part one, so we're bringing it back. This is our yellow brick roadmap. First, we're going to talk to you, or I should say, Ana Maria is going to talk to you a bit about personal care and CDPAP, the Consumer Directed Personal Assistance Program. Then I am going to come back and talk to you a bit about the appeal process or the request and appeal process. Ana Maria is going to come and talk to you about authorization standards for home care, including 24-hour care and span of time. Then I'm going to jump back in and talk to you about safety monitoring, informal supports, some other things, including task-based assessment. Ana Maria is going to come back and talk to you about some key tools and initial requests for more hours. And then I'm going to, hopefully we'll have enough time, but I'm going to then talk to you about reductions. So Ana Maria, please take us away.
Okay, so like Peter said, we're going to be talking about personal care. Typically, you see it as shortened as PCA, and Consumer Directed Personal Assistance, shortened as CDPAP. Next slide. Okay, so in the previous presentation with Peter and Wenru, they spoke to you about enrolling in home care, and today we're going to focus on home care authorizations and managed care. And the next few slides, I'm going to talk about this in broad strokes. Next slide. Before we begin, I want to lay some foundations. We're going to be discussing how to obtain home care services through Medicaid. Medicaid covered community-based long-term care services include all of the listed items you see here. Next slide. But when we talk about personal care assistance, we will be talking about the following tasks: bathing, dressing, grooming, toileting, transferring, walking, ambulation, meal preparation, eating, medication reminding and setup, and routine skincare. Next slide. These are the regulations that dictate home care services. Personal care tasks are defined under the New York codes and regulations. This distinction is important because depending on what kind of program a member is enrolled in, the person providing the care is subject to the restrictions in their ability to assist a member with their activities of daily living. For example, there are tasks that a CDPAP can do, such as putting medications in the client's mouth, whereas a PCA cannot complete such a task. Next slide. Continuing with the Wizard of Oz theme, we're going to be using this as a way to help explain the process of obtaining home care. Dorothy here takes care of her Auntie M, and Dorothy wants to make sure her Auntie M is receiving the needed home care hours while Dorothy is gone to ensure that Auntie M is not left without someone helping her with her activities of daily living. Next slide. And so now we're going to review how Dorothy can go about doing this. And this section applies only to people who have already been authorized for home care. So they've already gone past the NIAP level. They've already picked the plan that's going to provide their care. So this is where, if you are in the process, where you're going to be taking Peter's direction.
Okay, so thank you. It's important to start off with like the basic understanding that when uh, the a managed care plan does something, uh, like is it an actionable something or is it not actionable? Or I should say appealable or not appealable? Is it an action? There are two adverse actions that do trigger appealable notices broadly. One is when you ask and the plan says no, or you ask and the plan says, uh, maybe, not all. So like either it's a full denial or it's a partial denial. Um, say that Dorothy asks for 24-hour care for Auntie M, and the plan comes back and says, no, we'll give her 10 hours a day. That is a denial. Dorothy did not get everything she asked for, or Auntie M didn't get everything that was asked for on her behalf. That is a denial. Um, and likewise, if they just say no, period, and don't even give her a little bit of extra help, that is that's more straightforward. That is a flat out denial. But the notice will say that it's a denial, or the notice should say that it's a denial. So you ask, the plan has to send you a response in writing saying what they did, and then you have the ability to appeal. The second type of action that triggers an appealable notice is a reduction. Either they take away some of what you had or they take away all of what you had. Um, the classic example of this is the plan reduces your home care. So let's say that Dorothy wins 24-hour care for Auntie M, then comes back to Kansas, and the plan is like, oh, Dorothy's back, we'll reduce her services. But they don't know. Dorothy may have to go back to school, she's not totally available. So they should reduce, or I'm sorry, they should issue a notice rather if they want to reduce services. But they may not realize that Dorothy has to go back to school and she might want to appeal to prevent the service reduction from taking place. But we do see this with other services like daycare, um, and also discontinuation of services that um, I feel like that one's a little bit less common, but it does come up. For instance, quite a few plans, well, one in particular is coming to mind, but when somebody has 24-hour care or they just won 24-hour care, the plan might take away their personal emergency response system subscription, which the plan has been paying for, because they might think that you no longer need emergency support because you have 24-hour care. Um, the most important part here, though, is to recognize that reductions proposed are scary. What people don't always realize when we counsel them is that they are the most winnable cases. And there is a lot of protection in the law already preventing reductions from happening, or at least preventing them from happening easily. There's a lot of notice requirements. The plan has to issue the notice in advance. We have more on this later. And if you appeal fast enough, you can get what's called aid continuing, which means your services stay the same pending the outcome of the appeal. The TLDR here is check the mail and appeal quickly. So this is an overview of the appeal process, or the yellow brick road of appeals, if you will. Everywhere you see a gold bar, that is the plan's action being taken. And everything that is white is what the consumer would be doing. So on the left-hand side, the denial track, uh, the consumer puts in the request, and then the plan has uh, anywhere from 3 days to 14 days to issue a decision that can be extended. Also, the 14 up to 2 weeks. So really, we're talking 3 days to a month, but it's only a month if the plan first says we're going to take our time here. Um, the th that rule is also changing in January or it's supposed to change. I guess it could be delayed again, but it was supposed to start in April that the standard review timeline was going to drop from 14 days to 7. That the state was authorized by the federal government to change that or to delay that until January 2027. Um, so then in response, the plan has to issue a decision. The type of decision will depend on the plan you're in, but the vocabulary to take away is if the letter that the consumer receives says initial adverse determination or coverage decision letter, that is the adverse notice. Then the member has uh, up to 60 days to appeal. When you do appeal, again, there's an expedited track and a standard review track. After that, the plan issues a final adverse notice, and then finally, you can get to an external reviewer, either through a fair hearing or an external appeal. Broadly, we'll call those second level appeals. On the reduction track, same, everything is the same, except you have that aid continuing benefit. And again, the moral of this story is that if when Dorothy comes back from Oz to Kansas and the plan tries to reduce Auntie M's home care, um, Dorothy wants to appeal right away, immediately. Do not sleep on the notice. When you get the notice, if you see the words initial adverse determination and you read it and it says, we're going to cut your services, Dorothy wants to appeal immediately. Then there are some issues that are just not appealable by the consumer. Uh, a common one, I'm going to start from the bottom of this slide. A common one that people complain about is when a plan refuses to reassess a patient who is seeking more services to get out of a nursing home or a rehab stay. There is nothing in the contract that the plans have with the state to require this. It does seem uh, really problematic, I think, that a plan would not want to reassess in a facility, and there are some plans that do. I'll just to I don't want to throw everybody under the bus. I have seen a few plans assess in a facility prior to discharge, but not all. And when advocates have complained about this, the response has been that what I just said. There's just nothing to compel them to. Uh, Staffing problems. This is always a this can be always be a challenge because some people live in harder to serve areas. Some people um, are more remote than others, right? And then there's also language needs that can be an issue too. And there, a consumer-directed personal assistant might be um, a solution, but not appealable. This is not an appealable issue. Unless the plan sends you a letter saying, we can't staff your case, so we're discontinuing your services, that would be appealable. But the mere inability to find an aid is not appealable. Um, Quality of care, your aid is always late. You have problems with your home care agency. Maybe there's a real breakdown in communication. I once had a client who could not, he observed the Jewish Sabbath on Saturdays, and his home attendants, they, due to some construction that was happening in his home, they could not use his main entrance, but there was a side door that he left unlocked. And the home care agency or the plan never communicated, which we did tell them, that he cannot answer the phone on Saturdays. And the aides didn't know to go in through the side entrance. Uh, and they, well, that actually they did try to claim that he was refusing services, but and they tried to discontinue him. That was appealable. But the fact that they didn't ever communicate this issue was something to complain about. And then finally, contract limits. The home care agency is not responsible for, I'm sorry, the plans. The plans are unfortunately not responsible for compensating their home care agencies for overtime. So very often a consumer might experience pressure from a plan to, I'm sorry, from a home care agency to, accept a higher number of home attendants than the person would necessarily prefer. Another example is when the home care agency leaves the network. There are consumer protections for this, but they are not independently enforceable. You have to ask the plan to request an exemption from the state. So again, not appealable by the consumer. All right, now I'm going to kick it back to AM to talk about home care authorization standards.
Okay. So we will first be talking about the 24-hour definition of home care, and we will discuss requesting less than 24 hours in a later slide. Split shift means that the person has 24-hour needs and such needs that are so frequent that an aide would not be able to get 5 hours of uninterrupted sleep during their 8-hour period of sleep. Live-in care means that the member has 24-hour needs but does not have such frequent needs at night such that an aide wouldn't be able to sleep 5 hours uninterrupted during their 8-hour period of sleep. The CDPAP definition adds skilled nursing and home health aid tasks to this list so that the aide can complete tasks such as helping a consumer inject their insulin, which a PCA cannot do. It is important to know these definitions when requesting home care because although a member might request 24-hour live-in, they might get authorized for split shift if the member's dwelling cannot provide the aide with adequate sleeping accommodations. This means that there is no private space where the aide can sleep. This can occur if the member lives in a studio or if the other rooms in the home or apartment are occupied by others. Next slide. For less than 24-hour care, the regulations/requirements for less than 24 hours is less specific. The plans use a tool called a tasking tool, which Peter will discuss later. Essentially, it's a point system that the plan uses to determine how much care to authorize. But I like to remind consumers/families that if a member is receiving 24-hour personal care assistance through a combination of plan authorized care and voluntary assistance by the family, for example, the member is receiving 12 hours per day, 7 days a week, that's 84 hours a week of home care, and then the family provides overnight care, then that means that the member has 24-hour needs. As such, the MLTC plan may not use a task-based assessment tool to determine the plan of care, even if the member is requesting less than 24-hour care. And this rationale was codified in 18 NYCRR 50514, and it's known as the exception to the task-based assessment tool. This tasking sheet can be used to attack a plan's denial because the plan is not allotting sufficient time for the member to complete their ADLs in conjunction with the member's capacity to do these ADLs. And of course, if they use it for a client that is receiving, that has 24-hour needs, then you can point out that they're not supposed to use that task to make their decisions. Next slide. Under the regulations, the plans must consider an appellant's 24-hour need for assistance with predictable and unpredictable tasks or schedulable or non-schedulable tasks. The plan cannot arbitrarily determine a pre-specified amount of time without recognizing the span of time requirements. If a tasking tool used by the plan is used to determine a pre-specified amount of time without recognizing the span of time requirements, then it's not a credible tool, and one should argue that it should not even be given weight in a fair hearing proceeding. So what do we mean when we say that? Next slide. Unscheduled needs are essentially those tasks that one cannot plan for. One does not know when all of a sudden they will have the need to toilet and thus walk to the bathroom, so it cannot be called a schedulable task. This is even more so if the person suffers from urinary and or bowel incontinence. Schedulable needs are those tasks that can be scheduled. We recommend you read the tasking tool carefully, as sometimes the plan will sometimes not only arbitrarily determine a pre-specified amount of time for an unscheduled task, but sometimes they don't even account for a full 7 days a week. Additionally, the plans might not even allow for the member to complete an ADL or even list a number of times a member has to complete an activity in a way that is contrary to the member's capacity to complete such a task. Next slide.
Okay, that's me. So the next topic here in the world of how do plans authorize services, or what rules are they supposed to follow when they authorize services, is safety monitoring. And this is one of the well, a few, but this is an area where the law is pretty black and white. Uh, Safety monitoring is not a standalone personal care task. And what we mean by that is a few slides back when Ana Maria read all the tasks, there's like 10 that count as an activity of daily living, bathing, toileting, getting dressed, etc. Um, Safety monitoring is not on that list. It is not on the list, therefore it doesn't need to be covered. It's really that simple. But the guidance is clear that when someone needs safety supervision to ensure the safe performance of one of those tasks, then it does get covered, or it should be, because it's sort of what like when you think of span of time, right? It's do you need assistance with these tasks? What is the span of time in which you need the assistance? But the term assistance is kind of vague, right? That assistance can be on a spectrum from, uh, hovering over the person to total dependence on a third person to assist you. Um, where this comes up, I think the most is that, when someone is genuinely concerned for somebody's safety, uh, that's the only word our brains can conjure, right? We don't really think in terms of that list of tasks. We think, oh, my mom isn't safe alone. She wanders away. She forgets to turn the stove off. She cries out in the middle of the night for her own mother, who's been dead for 30 years. Like these sorts of things that are so heartbreaking, but they don't get you home care. That's just not how the rules are written. So if mom is waking up crying for her mother and also needs to go to the bathroom and needs help going to the bathroom, that's the track you need to be on. But the reason this is so important to know is that this provision is in 100% of the denial notices that you will read, no matter what plan. Okay. Next up, informal help must be voluntary. In practice, I think that plans sort of assume that family members or friends are doing something to help somebody, and kind of depending on that. I can't prove that. That is my own theory. But suffice it to say that when you are trying to uh, seek more home care, and the uh, there is an informal support, whether it's a family member or friend or a really benevolent neighbor, put it in writing. Put it in writing when the person actually is available, or if they're not at all, or if they are available, but it's just too inconsistent to be reliable, right? Like as long as you establish in the paper trail that the person uh, really should not be treated as part of the plan of care in a consistent sense of the word, that will help you in the long run. Okay, now Ana Maria sort of hinted at this before when she was talking about 24-hour care and span of time. But there is the product of litigation. There's a rule that's informally referred to as Mayor 3, which says that if you have informal support that is committed to assisting you, And thank goodness those people do exist that are so uh, willing and able to assist. Um, the uh, the plan, what they're supposed to do is treat that informal support as part of the plan of care. Uh, so if like Ana Maria's example, if the plan is providing 12 hours a day and family is providing 12 hours overnight, then the plan should treat that person as though they have 24-hour care. So let's say that Auntie M has 24-hour care, or I'm sorry, has 12 hours a day of care, and um, Dorothy is providing all the overnight care, and then she gets whisked away in a tornado, but she knows it's happening in this fantasy. Um, she knows it's going to happen, rather, in this fantasy. And she puts it in writing to the plan, I have this horrible, horrible luck, and I constantly get sucked up by these natural disasters and dropped off in mythical planes. Um, my aunt needs she's going to need help overnight, and you've known that I've been providing the 24-hour care. Then Auntie M really should be a Mayor 3. She really, and the plan should just authorize it. They unfortunately probably won't, and you will have to appeal, but that's just to illustrate the principle. Okay, next up, now that we've talked about what the rules say, um, we're going to talk about how the plans usually do things in practice, or at least from what we've seen at NILAG. First, the plans all use a uniform assessment. This is an excerpt from one section. The uniform assessment can run from like 20 to, I think I've seen as high as 30 pages. Um, so it's not a short instrument, and it is an interview tool. So the consumer, when a nurse is conducting the assessment, it should really take them like 2 hours to do it the right way. I've heard clients say that, the nurse is only with them for like 15 minutes doing this assessment. That's alarming. Um, and also you may remember that the New York Independent Assessor uses the same instrument when determining someone's eligibility for enrollment in a plan. We talked about that in part one. Uh, the assessment itself does not actually determine how many hours the consumer is going to receive, but it does inform the assessment. I'm sorry, the authorization of services. The plans will review this, and they will use their own proprietary task-based assessment tool to make the authorization. And as Ana Maria said, it's sort of a point system, a task-based assessment. They give you credit based on your level of need. They should also be looking at when you need the help throughout the day. That's the span of time requirement. But that doesn't always happen. Um, Task-based assessments look different from plan to plan. I have an example of an excerpt of an example of just one for you today. Uh, so if you could just take it all in for a second, I want you to first look at the top row, and I want you to look at the one, two, three, fifth column. It says times per day, right? Now, and I just want you to see how sort of, I think, well, sort of arbitrary this can really be. And this is a very recent case of mine. This isn't like pulled from 10 years ago. Now go all the way down to toilet use, the bottom row, and it says that the consumer toilets or uses the toilet 3 times a day. Now, now go all the way to the far right column, and it says max number for times per day. And for toilet use, it says 6. I mean, my first question for this person is why the plan decided that they only toilet 3 times a day when the max number is 6. Another thing to look at here is the UAS response column. That's the third column. You'll see for toilet use, this person got a 5. Remember, I said before that the level of assistance that you need exists on a spectrum from totally independent all the way to totally dependent on help. And back on the uniform assessment system, you'll see these are for two different clients, just so these don't match. But if you look at the right-hand column, you'll see like for bathing, it says this person needs extensive assistance. For personal hygiene, this person needs limited assistance. And the assessment codes, like I said, from totally independent to totally dependent on assistance. It's a scale from, I guess that's 0 to 6. Um, maximal, sorry, a 5, which again is the UAS response for toileting. A 5 is pretty high. That's one step down from totally dependent. So not only does this person need a lot, only magically toilet 3 times a day, but they need a lot of help doing it. So just, I mean, again, just to show you how some of this really does become arbitrary, but I think a lot of people shy away from scrutinizing task-based assessment tools because there's so many numbers and they all look different, but you really can mine them for uh, some good points when you are appealing. And now I am going to hand it back to Ana Maria. Sorry, I just prematurely muted myself to talk to us about some key tools in home care advocacy.
Thanks, Peter. Okay, so now that you've learned the distinctions in home care, the standards of home care, and how plans determine how much care to authorize, we're now going to discuss the best practices for preparing to ask for more home care, how to make an initial request for more home care, and what to do if a client gets a reduction notice. Next slide. 2 important documents that you should have on hand to make the request for more home care so that it goes a bit more smoothly are a HIPAA and a managed care authorization form, which tells the plan that the consumer has authorized you to put in a request for home care on their behalf. Next slide. Before we move on, though, I want to discuss good case hygiene. This isn't just for our benefit, it's also for the benefit of the client. Plans often lose requests or process the request wrong, and having a paper trail will ensure that we can show proof of when a request was made and whether it was done properly. If one cannot make a request in writing or email, the second best option is to collect the information of who you spoke with and follow up with it in writing if possible. Next slide. The paper trail is also important because the home care rules and regulations dictate how quickly a plan must respond to a member's requests. We want to make sure that when the plan denies the care, that they cannot say that they did not have all the information needed to make their decision. And when we get to the external appeal level or the fair hearing level, we can show that the plan had knowledge of the member's need and still denied care. Next slide. And so now we're going to talk about the documents and that you can collect to submit with your request for more home care. A doctor's letter is important because, as we learned earlier, we have the burden to show that the consumer needs more home care. These letters will allow us to show how the member's medical diagnoses impact their ability to complete their ADLs, or activities of daily living. Next slide. So these are the elements of a good medical letter. Items 1 through 6 should always be included in the letter, except for the last 2, which will be covered at a later presentation. We want the physician to write a thorough letter, but we don't want the physician to include safety and supervision language. However, we don't want to tell the doctor what they can and cannot write, so instead we encourage the doctors to instead focus on what the member needs assistance with, which is primarily the activities of daily living that I listed earlier. Next slide. Often, physicians will write letters that only list the member's diagnosis and then write, because of their condition, they need more home care. Although it's useful to have this information, it does not give us a lot to work with. Additionally, this information is often found in the plan's assessment tool, So a doctor's letter with just the member's diagnoses is sometimes duplicative. More importantly, the regulations state the language says because of the patient's medical conditions, they need assistance with dot dot dot. So we want the doctor to thread the needle between the member's diagnoses and the reason that they need assistance with their ADLs. The doctor should focus on the member's ability to complete the key ADLs of toileting, walking, transferring, turning and positioning, or feeding. If something does not apply, the doctor can explain that. For example, a patient might not need assistance with walking because they're bedbound. Next slide. In addition to listing the medical condition and the activity of daily living, the member needs assistance with we also want the doctor to include not just the type of assistance the assistance the member needs, but the type of assistance the member needs. The assistance can be supervision, oversight queuing, limited assistance, extensive assistance, maximal assistance, or total dependence. Supervision, oversight queuing is self-explanatory. Limited assistance means guided maneuvering of limbs and physical guidance without the aid taking the member's weight. Extensive assistance means weight-bearing support, including lifting of the limbs by one helper, where the member still performs 50% or more of the subtasks. And maximal assistance means weight-bearing support, including lifting of the limbs by two or more helpers, or weight-bearing support for more than 50% of the subtask. And total dependence means the full performance by another during the entire episode. Next slide. Here is an example of a good letter from a doctor. Under mobility, it says that the member has arthritis and lower back pain, which does not allow them to walk in a stable manner. It also states that the member is so impaired that they cannot do it if they're home alone. For bathing and toileting, it says the member has prostate cancer, and as a result, he wears a catheter bag, and the member cannot change the bag themselves. Under dressing, the doctor states that the member has arthritis, which makes it so painful that they cannot complete the task at all. We have one more example. Next slide. This letter is a little different. This letter mentions the member's diagnoses at the top. It also mentions that the member has some voluntary support from their daughter who completes tasks that the PCA cannot do, meaning giving their parent their insulin injections. This client has dementia, and although sometimes a client with dementia might struggle with physical ADLs and need limited to total dependence, they may sometimes need supervision queuing for tasks like eating because without someone being present, they may not eat the food prepared for them. In sum, these letters must really look at the whole client. We can give doctors a sample of a good letter, but ultimately it is the doctor's job to write a letter specific to the member's needs. Next slide. Of course, sometimes doctors will not always write a letter, or maybe the member cannot get a letter from the client for the client in time. That happens. There are alternative documents that can be used, such as hospital records from a visit to the ER, or a visit summary from a doctor's appointment, or a referral from PT, results from a medical scan, a letter from the PT or OT, or records from a rehab or a nursing facility. These can all have useful information. The only thing that I watch out for in these letters is that they do not include safety and supervision language. And as a general rule, I do not like to use supporting documents that mention those words unless it's written in a way that connects it to the completion of an activity of daily living. For example, the member needs assistance to walk to the bathroom and her bedroom safely. Next slide. Another helpful document that helps the case significantly is a personal statement from a family member or a friend who provides voluntary care. Similar to a doctor's letter, we like the letter to be thorough. The family member or friend does not have to list the diagnoses, but if they do, it's okay. This particular letter mentions the member's inability to complete their ADLs, walking, toileting, turning and positioning, transferring, and feeding by themselves. The letter also mentions whether that the member suffers from urinary incontinence, and your letter should include concrete examples such as the member needs verbal cues or reminders, but the letter should lead with things that the patient needs hands-on help with, such as the ADLs first. Family should mention what kind of support they currently provide and why they can no longer provide such care for the member. Next slide. Members are their own best advocate, and you can assist them in telling their story by helping them write their personal statement. Similar to the doctor's letter, this letter lists the diagnoses and how the diagnoses impacts the member's ability to complete their activities of daily living. It focuses on the ADLs: walking, toileting, transferring, turning and repositioning, and feeding. They should also mention whether they have incontinence of urine or bowel. You'll see that it does not mention safety and supervision language. And this letter is written by the appellant, and so we can add more to this letter aside from the required language. Next slide. Okay. So, for example, in this letter, the member addressed that they have medical equipment and supplies. However, they cannot use them by themselves. The reason I had the member include this is because often plans use the rationale that the member has medical equipment or supplies, and so that will meet the member's needs. However, we know that just having medical equipment or supplies alone are of no use if the member can't actually use them unassisted. For example, the member has diapers, but they can't change the diaper themselves and they need total assistance or limited assistance. Otherwise, they have to sit in that diaper until someone can come home to help them. Next slide. And finally, as this is not a doctor's letter, I always like to ask my clients, after we've covered all of the most important parts of the letter, to include a sentence with something that they would most like the ALJ or the external appeal panel to know. It makes the letter more credible and humanizes the member. It's important for this to be a part of the paper trail because it tells the judge that the plan had all this information and they still ignored the member's needs. As you can see, this section does not speak to the ADLs, but instead it speaks to the human and humane aspect of care. And we won this external appeal for this member with this letter. Next slide. This is an additional support document that goes a long way, whether you're asking for 24-hour care or less. And it's a letter written by the aide. This is an important letter if you can get it, because your aide spends the most time with the client, and so they know what their needs are. This letter is typed because the aide only speaks Spanish, and we had to translate it. We included both the letter handwritten in Spanish as well as the certificate of translation and the English translation. And this letter explains not only the help the member needs, but how the aide helps the member. The letter does not mention safety and supervision, and it also addresses the aide's need for sleep and the fact that they're not getting their required 5 hours of uninterrupted sleep during an 8-hour period, which goes towards the language that's in the regulations. Next slide. The logs should only mention the activities of daily tasks that the aide family member assists the member with, meaning walking, toileting, transferring, turning and positioning, and feeding. I know I sound like a broken record on that front, but those are the key ADLs. Do not mention tasks such as the member wanted to chat or the member tried to get out of the bed by themselves because they said they needed to go to work, or the member asked me to turn the TV because they wanted to watch The Price is Right, etc. As you can see, it mentions that the member did not want to go to sleep, which is actually okay within the context of the entire document. But these logs should be detailed. And the log should not be identical for every night. Otherwise, it raises questions of credibility. They should be written by hand, again, because it lends towards credibility. It should include the name of the person who wrote the logs, the date, and their signature. This sample log was handwritten in Spanish, and we translated it into English. And we also won this external appeal with these logs and the personal statement from the aide. Next slide. Okay, so now...
Actually, Ana Maria, there are two questions that I think would be good to answer now since you just covered all of those.
Yes.
Actually, one of them is for me, and I'll just answer it. There was a question about the levels of assistance, and I'm sorry, I did not include a slide on that, but it was included in the ones that Ana Maria listed, from totally independent to totally dependent. That is part of the uniform assessment system, and we did have a slide on it in part one, because remember that the New York Independent Assessor Program uh, uses the same tool. Question for you: can writing be emails or should it be US mail?
You can send it if you're emailing at the internal appeal level, yes, you can send it. Usually plans have an email address where you can submit all the documents. So, but there's one plan, I'm blanking on which one it is right now, that doesn't have an email, and so you kind of have to rely on the post office. But overall, yeah, you can email it to the plan.
Yeah, and I'll just say I've had clients who had to do it by email. Um, like some people can, as an accommodation, as long as it's written, that's really what should matter. Uh, and then I see one other question. You mentioned adding a personal message at the end of the letter to humanize the client. Can you provide an example?
Yeah, we can go back to that slide. So this particular member wrote, it's very frightening to be alone at night, knowing I cannot complete any of these activities of daily living. Even managing the covers, blankets on my bed is very tiring. I often drop things and cannot pick them up. I can't see in the dark. It is undignified to be left in a wet diaper at night and dangerous due to the possibility of getting sores or even a UTI. And so these are not speaking to the ADLs necessarily, maybe the diaper one, but well, yes, to the diaper one. But we don't talk about we take for granted so many of the things we can do. And so the client mentioning being afraid of being in the dark because they can't go and turn on the light, or the blankets being too heavy that they can't lift them up. And so these are things that are not part of the regulations, but it tells the judge, like, this person is not it has a lot of needs, and even the simplest things that we take for granted are very difficult for them.
Okay, and then let's do one more, which I'll take because it gets at something that I regretted not mentioning in my last section. Is it more helpful to send the letters from the doctor, consumer, or aid and night logs to the plan when making the request? Uh, for example, during the eternal appeal, or is it better to wait until the fair hearing and or external appeal? Second question, is external appeal better? Um, I think that the process is what the process is, but meaning, request, denial, internal appeal, another denial, second level appeal. But the plan has a duty to provide services that are medically necessary. So I'm of the view, and I don't know if everybody agrees with me on this, but I'm of the view that if you are putting in documentation into the record and you're keeping a paper trail, the plan should be reviewing it full stop. And it doesn't really matter when you submit it. I think there's pushback, though, that it should at least go in before the final adverse determination. That's coming from the plans because it serves their purpose of denying. Well, I'm sorry, that's not. It's not their purpose to deny services, but it serves their end of denying services. And I don't really think one is better than the other, whether it be external appeal or fair hearing. I do think that fair hearings um, have the benefit of providing aid continuing for a reduction in service hours. So I would probably never do an external appeal of a reduction in hours, but that's really the only place I would draw the line. Okay, Ana Maria, let's get back to it. I will queue up your slides. And
Um,
just to go back to that question I just answered, even though this says initial request for more hours, um, all of the principles that Ana Maria just said can apply at any stage. Go ahead, sorry.
Yeah. In fact, I just got an email from a client that I helped them get 56 hours, and they now need more care. And my advice was, well, how much care do you want? And, I told them, okay, these are the documents that you should start working on so that we can have all this ready to go once you have the request, once you're ready to put in the request. And if it's not possible, then we'll get it in at the once we file the internal appeal. So, it's when you can, sometimes it's hard to collect all these documents. Okay, so now that we've learned what kind of documents to collect before you put in your request for care, we're now going to discuss the process of requesting more home care hours. Okay. If the member is or the member's representative is making the request orally, it's important that they say something along the lines of, I am requesting X number of hours because my condition has worsened and I need more assistance completing my activities of daily living. Remember to not mention anything related to safety and supervision. And because what one says at this stage is being recorded and it will appear in the written record. So it's important to use the correct language even when orally notifying the plan that the member needs more care. Remember to keep a paper trail. Next slide. In addition to these documents building our record, this paper trail can be used to file. So these are the notices that you're going to receive once you put in the request. You will more than likely be denied. And so these are the standard notices that you'll receive. In addition to these documents building our record, this paper trail can be used to file a complaint against the plan for failure to respond in a timely manner. This is an important advocacy tool. In the past, I was able to secure an increase in a member's care without, not on the merits, but because the plan failed to respond within the time set out by the regulations. Further, it's important to keep track of the dates you submit your request, as one can file. You can file this complaint. Next slide. Okay. So you can ask for a regular request or an expedited request. The plan has to process an expedited request if the member or their doctor specifically asks for the request to be expedited. The doctor's letter must specifically state that a delay would seriously jeopardize the enrollee's life or health or ability to attain, maintain, or regain maximum function. If only the member says this, the regulations give the plan more flexibility for responding to the request for more home care. So, be mindful of who requests the expedited appeal. It must be the doctor. Next slide. Okay, so back to the yellow brick road. You will encounter a consumer at any stage of the process of seeking increased hours. And we at NILAC intervene at all stages, and we will work with you on these cases at all stages. Reductions are scary, but these are the most winnable cases. You just need to appeal them, and Peter will talk about that later on. But as to the time that you have to put in a request for the plan to answer your request, New York State just granted an extension to January 2027 to come into compliance with the federal rule requiring that the standard review timeframe to drop down to 7 days. So for the time being, it's going to remain at 14 days. So just be mindful of that when tracking when the plan responds to you. Next slide. So this is what an initial denial looks like. Once you put in the request for care, you'll likely get denied. But depending on the Medicaid product that the member is enrolled in, then the notice will say initial adverse determination or IAD. If the member is enrolled in a managed long-term care plan or a MMC, and it will say coverage decision letter if the member is enrolled in a MAP, Medicaid Advantage product. The notice includes the date the notice was sent and the date the member must submit their appeal by. As mentioned earlier, you have 60 days to appeal. And once you file your internal appeal, the plan has up to 30 days to decide or 72 hours to decide if expedited. You want to make sure to check that the notice states the correct name of the member, the correct hours the member currently receives, and the correct number of hours requested. Fixing this sooner rather than later is best. The notice here includes an appeal page with the information on how to submit your appeal, and the supporting documents can be sent by mail, fax, or email depending on the plan. Sometimes people will orally appeal the decision if they have nothing to add to the record, and that will suffice as an appeal. Next slide. These are two samples of a final denial notice. Again, after you file, you could win the requested hours, but that doesn't happen as often as we would like. And depending on the Medicaid product, it will say final adverse determination or FAD if the member is enrolled in an MLTC or MMC, and appeal decision letter if the member is enrolled in a MAP. The notice includes the date, the notice was sent, and the date that the member must submit a request for a fair hearing by or file their external appeal by. As mentioned earlier, a member has to request a fair hearing or submit their external appeal 4 months before the receipt of the notice, aka 120 days. Make sure to check that the notice states the correct name of the member, the correct hours the member currently receives, the correct number of hours requested, and this notice will include a page with the information on how to request a fair hearing or submit an external appeal. You will need the member's enrollee number and the plan reference number when requesting the fair hearing, and that information can be found at the top of the page.
Okay, I'm back. I think Ana Maria said this. I want to make sure people heard this correctly because I think she said it differently. But requesting a fair hearing or external appeal, you have 120 days from the uh, day that the notice is issued to request the fair hearing, or 4 months to do an external appeal from the day that the notice is issued. I don't know if it was me that heard it wrong or she may have misspoke, but um, okay, now we're going to talk about reductions. Before I jump into this, there's a question that in the Q&A that jumped out at me that just on in terms of benefits of like external appeal versus fair hearing, that a fair hearing decision trumps an external appeal decision. So it could be a good strategy to do the external appeal first, and then if you lose the external appeal, request a fair hearing. I agree with that. Um, the basic premise of it, I don't know if I agree with it for reductions in services, only because uh, well, again, the aid continuing thing I said before, right? When you're facing a reduction in services, you have the right to aid continuing at the second level appeal only through the fair hearing, not through an external appeal. Um, if you lose your external appeal, you that decision is admissible as evidence in the fair hearing. And I don't, the hearings had anybody that does fair hearings knows that the last 6 years of fair hearings in the home care space have been weird. I don't know. A lot of them have been resolved informally. Some of them are still outstanding. I think there's a lot of loss of institutional knowledge because, the Great Resignation affected so many sectors of our economy that I just don't love the idea of potentially losing an external appeal on a reduction. And then, yes, you can get aid continuing for the fair hearing, but if I don't know what a judge would do with that. Like if you lost the external appeal, right? So um, I just wanted to comment on that live. All right, now reductions. This is the home stretch. We're almost done. Thanks everybody for hanging on. Uh, so when Dorothy returns to Kansas, Scarecrow, Tin Man, and Cowardly Lion all receive calls from their home care agency that their home care services are being reduced or discontinued. Dorothy just can't catch a break. Scarecrow is in an MLTC plan, and his home care hours are going to be reduced from 12 hours a day to 7 days, from 12 hours a day, 7 days a week to 6 hours a day, 7 days a week starting Monday. Tin Man is with the Department of Social Services, while Cowardly Lion is in a mainstream managed care plan, and their home care hours are being discontinued altogether. Dorothy hitches a ride on another tornado to go back to Oz to help them all, but what is she going to do when she gets there? So, first, reductions have, I think I said this way earlier, but reductions and discontinuances have some good protections in the law. And the first one is the notice that the consumer is entitled to. Any action to take away services from a consumer must be in writing in the mail at least 10 days prior to the effective date of the reduction. The notice also has to be adequate. The notice adequacy section of the regulation is pretty long because it accommodates other programs too. It's like SNAP, I believe, and I think also the Home Energy Assistance Program. But Medicaid is in there. Medicaid services are in there. And then there's a provision that says that the Department of Health may require the use of forms. It develops or approves for providing notice to sort of simplify things for the plans, but there are still some problems. And then they have to give a reason. That's the big adequacy concern that we see a lot in reductions. But it also has to, a very, very threshold one though is the action even correct? So just to give you some examples, on the left, we have an example of a very basic notice adequacy issue this is from a couple of years ago. And sorry to, I'm trying not to throw any specific plans under the bus, but visiting nurse service MLTC, you'll see at the very top, the notice says it's a denial notice. But then if you read the actual action being taken, this is the bottom two on your left, it plainly says that the services are being reduced. So right off, in my view, an ALJ should just throw this notice out and cancel the action altogether. And also because it's defective for adequacy, the plan made the effective dates the effective date the same as the date that the notice was issued, August 3rd. That's improper, right? It's this one's not only defective for adequacy, it's also defective for timeliness. And then a very basic example of timeliness. This is from Center's plan, which is no longer a plan. It was acquired by Anthem, Blue Cross Blue Shield's MLTC plan earlier this year, I think. Earlier this year, yeah. Anyway, and in this one, the notice was issued a month after the action had been taken, right? So see August 22nd, 2022, effective July 26th, 2022. And this was an action to stop social adult daycare. And one other point I wanted to make here is that for timeliness, sometimes, so this page that I'm showing you is kind of buried in the notice. It's way down. We've been told that, like where it says for New York State OTDA only, we've been told that this is the page that the hearing office is really looking at closest when they are evaluating a request for aid continuing. So this is like why you want to get every page of the notice, because this is so buried. But another, by the time you get there, you've gone through so many pages that may list other dates. So we've seen notices to reduce services that say that the deadline to request aid continuing is 3 different dates, right? And like that is also a timeliness defect. You should be able to read the notice and have no confusion from top to bottom, every page, and have no question about what the deadline is to appeal to get to have your services stay the same. It's just a basic cornerstone of due process. You need to know what is going on and what you need to do to stand up for yourself. Now, also on the adequacy front, aside from just naming the action, a specific reason needs to be listed. And this is pulled straight from the reg, but it's also been litigated in a case called Mayer v. Wing. And I'm just going to zero you in on the stuff that's underlined. Permissible. So the first it says must, right? The plan must deny or discontinue services when they find that the services are not medically necessary. They may have once been medically necessary, but they no longer are, or they believe that the services will not actually continue to maintain you safely in your home. That last one is something that you might see when somebody, goes from needing personal care to nursing care. Ana Maria said earlier that, like there's some tasks that a personal care aide just cannot do, like administer insulin, but a higher level aide might be able to. Like that's an example where the plan or the district reasonably could expect that the services that you currently have uh, won't maintain you. Now, also the plans have a duty to coordinate your care. So I would hope that they would also be working to help you get services that you actually that actually would maintain you. I don't know if that always happens. Okay, next, let's go. Here we go. Oh, sorry for the typo in the header. Again, this is a continuation of the same idea. The specific reason for a reduction must be given. And from Mayer v. Wing, there were several reasons that were that came out of that decision that are permissible. The first one is by far the most common that we see, where the plan alleges that the services are no longer appropriate due to some medical or social change in the patient's life. They often misapply this, and there is a guidance document that everybody should read, linked at the bottom of the slide. It's an MLTC policy that came out of some litigation that NILAG's litigation team brought several years ago now. And it basically says that you have to explain what the medical change is for the medical reason. Like what is the change? What changed in this patient? How that relates to their need for assistance, and why, as a result, they should have less care. And this comes right out of the regulation also. There needs to be some kind of demonstration that services are not medically necessary, no longer medically necessary, or are no longer medically necessary, and they have to give a clinical rationale that shows what was reviewed here. And I think key is the last line, be sufficient to enable judgment for possible appeal. That's the whole point of notice. I need to be reasonably appraised of what is happening so I can make the decision of whether I will appeal. Like what if the notice says that we're taking away your home care because you know how to fly? Like you are physically capable of flying. You have wings. I mean, my appeal would be, I absolutely do not have wings, right? Like you want to be able to say this is preposterous. I disagree. Okay, now some reductions may be less obvious. One is where cases are mutual. That's when they share hours. One person leaves the household and the services for the other get reduced immediately. I think I'm coming very close to the end, but I promise we are very, very, very close to being done. I hope you can stay on. The consumer requests the increase, the plan denies it, and they totally ignore that a reduction occurred. The person who's still in the household should have the right to appeal that as a reduction. Another example is when you're in a facility for any amount of time, you have the right to reinstatement of your hours. And if they want to take the hours away, you have the right to notice there too. Another one is transitioning from fee-for-service, which is straight Medicaid, to managed care. There you have a continuity of care right for 90 days. But at the end of that 90-day period, the plan can try to reduce your services with advance written notice. And they no longer require a mayor reason, but you'd still want to appeal, like what happened? Like why, like if the assessments are the same from when I was in fee-for-service home care, and now that I'm in managed care, why are you reducing my services? Okay. Some discontinuances may not be typical. Remember, Tin Man and Cowardly Lion are not an MLTC. One is at the DSS, one is in mainstream, and their home care hours are being discontinued altogether. This could be because they lost their Medicaid. And we've been seeing that, unfortunately, because post public health emergency, people are missing their renewals, or they're not getting processed. There's been a lot of trouble that we've seen in this area. And when that happens, you need to appeal both the discontinuance of the Medicaid and the discontinuance of the home care. And if they were disenrolled from a plan, you have to appeal the disenrollment from the plan. It's really a headache. Another thing that we sometimes see is that when someone becomes eligible for Medicare, they move from a mainstream plan to an MLTC plan. Um, I'm sorry. When people are disenrolled from, they're supposed to be disenrolled from a mainstream plan to fee-for-service Medicaid unless they are receiving home care. Um, and the way this transition happens, mainstream plans are supposed to report home care recipients to the Department of Health. We've seen a lot of trouble there too. They're not always getting reported, and these consumers sometimes do lose their services. Um, so, in the Cowardly Lion example, if he's misreported as a non-home care consumer, then he could potentially lose his services. And then this is just restating something I said in an earlier slide that the plans must restate your services after a hospital stay or rehab stay at the same level. Um, that is the last of it. Thanks for those who stayed who stayed in the webinar. Um, I don't know if we have time for questions. Now I'm the only one. Rebecca, what do you think?
It's nice to see we're all up here now. Yes, I will echo Peter's sentiment. Thank you for staying with us. We were answering, or I was trying to answer questions as we went along. I will just reiterate that this presentation will be posted online on NILAC's YouTube page, and we will make the slides available as well. Feel free to join our newsletter, or be in touch with us at flrp@nilag.org. We have a little special statement there. Do not delay in requesting a fair hearing, especially if we need it to continuance on a reduction or discontinuance. So I think with that, we will probably wrap up because we're 2 minutes past the hour. And we very much appreciate everyone's participation. Thank you.